Cota is a data and analytics platform that was formed out of the John Thor Cancer Center. Our goal is to help develop and build a research-grade, real-world data set that can be used by doctors, by members of the payer industry, and by pharmacy industry to help solve questions that couldn't be done using clinical trials, but might be better solved using real-world data. Cota is designed to work behind the scenes. We're not asking the doctors or the nurses or any hospital personnel to do extra work. We know that they don't want to do that. So what we do is we hook into the existing health electronic record that that hospital particularly uses. So if it's a big hospital and they use Epic, or it's a smaller hospital and they have some homegrown, we pull off using what's called HL7 or FHIR integration. These are the ways that we pull information out of existing health records and then organize it in a way that makes oncologic sense. We then feed that information back to the hospital in a way that can help them understand what they're doing so that they can enter into better value-based models. And we also send them back information in a de-identified fashion from the whole system so that they can benchmark themselves against other hospitals that are the same size or against the whole nation. And we do this all in a HIPAA-compliant fashion so that we stay within the ability to do privacy, because that's an important issue for most IT and most healthcare workers today. Value-based medicine is the rage. We're moving in a time when we're going to go from fee-for-service to value-based medicine. We see that even at the federal level with MACRA, which is the new Medicare. And it's predicted that within the next 5 years, 90% of all payments are going to be some value-based. And so in order to do that, the people in the financial world need to have an idea of what kind of patients they're seeing. Really understand exactly what they're seeing, because a simple breast cancer patient is very different than a very complex breast cancer patient, and the cost may be very different. You would treat a patient who's got a small tumor that's hormone positive just with hormones very cheap, whereas the triple negative patient may need expensive chemotherapies. And so each hospital needs to know what kind of patients they're seeing, categorize them properly, and then follow the costs so that they know their patient mix and the costs even down to the granularity of the type of patients that they see. Cota was designed to give the financial officers that type of granularity of what they're seeing. The current ICD-9, ICD-10 systems, the billing codes that most financial people are used, just say breast cancer. Don't give you any granularity. And that's not going to cut it in a value-based world. Quality is another major concern for hospitals, be it patient satisfaction, be it are they meeting the so-called QOPI standards, the quality assessment from ASCO, or the PQRS from the feds, or the OCM requirements. We have a lot of quality measures that keep being pushed on oncologists, rightly, because we want to have quality care. And in a value-based medicine approach, it's going to be quality divided by cost. Most practices have no idea what the quality is. And what we have to do at our practice is we have to send nurses down every year and pull out charts and do hand quality assessments to be able to meet these federal standards. What Cota was designed to do is pull that data out electronically from the electronic health record, organize it so that the quality officers can have information to fill out all these forms and to make their certifications, and also to point out where they're doing good and where they're doing poorly so that they can improve their quality in real time.